Welcome back to those of you who have been away for a while. This morning we get to hear from the newest and the youngest member of the faculty of the School of Religion. Let me tell you how he got here. If you don't believe in providence, you will now, okay? Some time ago, a mutual friend introduced Alex and me, and I thought he was a nice-looking young man. And the mutual friend left us a CV. And I looked at that, and I said, this is unbelievable, so I put it on the table. And then I was talking to Roy Branson in Roy's office, and he had one there. I don't know how he got it. And Roy said, well, what do you think of this CV? And I said, I think it's a prank, and we shouldn't fall for it. He said, you know, that's exactly what I think, too. So he put it aside. And it was some time, in months. And then we found out that the Adventist University of Health Sciences down in Florida had hired a person whose name was the same as this prankish CV. And we thought, whoa, let's go look at it again. So we looked at it again and did some study and so forth. And we found out that there is really a human being of this name, of these qualifications, and so forth. Alex is from Ukraine. He studied at Andrews University. He has been a chaplain at Emory University. He has taught at Yale University. Long line of presentations, which is unbelievable. I already told you that, and peer-reviewed publications. And he was just finished up his PhD at Duquesne University, and we were able to persuade him that God was calling him to come to Loma, Linda. The people in Florida didn't see it that way, and they expressed themselves quite clearly about that. But Alex followed the hand of God and came here. Anyway, so here we have Alex. It's wonderful. At first we had him doing part with us and part with the School of Public Health because he really does work that looks like epidemiology. But then we said, no, we need him here full time. So now he's with us full time. Let's begin with prayer. Dear God, thank you for Alex. He's unbelievable, but he really is real. Help us to learn from him today. In Christ's name, amen.
Thank you for such a nice introduction. I don't know how to follow to this wonderful words. Thank you so much. So, Dr. Larson asked me to give the same presentation I gave just a few weeks ago to faculty, the School of Religion, and the presentation was about the way we make decisions, and the way we make decisions in healthcare, especially, and so I had a long-term interest in decision making. When I was in Pittsburgh, they have in Carnegie Mellon they have a cognitive behavioral lab where they study decision making for different in different areas, in financial decision making, healthcare decision making. And so I wanted to share some things with you from that area and maybe apply it to healthcare today, and maybe if there will be a chance to talk later. So today I just kind of wanted to talk in general about the way we make decisions. And then later on, maybe at another occasion, we can apply this to ethics and morality, and not ethics and morality only, but to specifically to religion, for example, talking about how we do charity work and what kind of decisions involved into charity, how we perceive justice and fairness from the perspective of behavioral perspective, not necessarily from so more from a descriptive way. So, and my apologies to those who already seen this presentation. I guess a little bit of repetition. So today I wanted to talk about nudges in healthcare, and I wanted to start with this illustration. I don't know if you can see well, but on this illustration, I don't know, would you say that this color is exactly the same as this one? These two on top and the bottom. So it really doesn't look that way, but if you shade all the areas on the Rubik's Cube, you'll see those two colors are exactly the same. What's interesting about these visual illusions, when you look at it, if you put back the slide, you can't look at the first one and say like, oh, now I see, now I understand, now I learned, I see the point. No, it's, you know, if you look back here, you know, it's exactly, it looks the same way as in the beginning. You can't really figure it out. There's another cognitive visual illusion. If you look at these tables, would you say that they're the same length? No, it doesn't seem that way, right? But if you transpose it, if you do this, actually they are the same length. You just, you know, the way our vision makes tricks. So it's a visual illusion. But again, if I'll put it back, you cannot say like, oh, now I learned, now I see what's the issue. It just doesn't seem that way. And so what's interesting about this, and the reason why I wanted to show this, is because vision is what we do on a daily basis, and that's the way we interact with the world. So suppose a big part of our brain is dedicated to vision. We have so much in our brain that processes vision and visual things. And so we make predictable mistakes in vision, and they have this visual illusions. And so it's very plausible to assume that in the area of decision making, we also may do similar mistakes because there are some decisions that we're just not good at. And so I wanted to show you the way we do mistakes in decision making. So this is like a famous study. I don't know if you've seen it. It's about rates of organ donors, registered organ donors, in different countries in Europe. So you see on the left-hand side, countries with there are not many donors here, just a few registered organ donors, versus on the other side, numbers are so high. So what do you think, what accounts for the difference? Why there is this difference between these countries and that countries? How would you explain this? Any guesses if you have?
I would say that on, like, say, the driver's license, if you say, I will donate, or I passive versus active.
Yes, yes, very close. Yes, yes. But some people started trying to guess as well. Maybe culture explains it. But if you look at the countries, they're very similar culture-wise, right? Germany and Austria very similar, Denmark and Sweden, Netherlands and Belgium very similar, and depends how you see Europe, United Kingdom and France is also very similar. Some people say maybe it's the way they do campaigns, and it's what's interesting in Netherlands, it's like the highest here. What they've done, they mailed letters to every household in Netherlands begging them to register. So when they say begging gets you that far, it's 28% in Netherlands. What's the difference is the way questions are phrased or framed on the driver's license. You were right. In one country, some countries, on the left-hand side, this is the question. This is the question we also have in our DME, right? This is kind of the way it looks like. Check the box below if you want to participate in the organ donor program. So, but on the countries on the other side, check the box below if you don't want to participate in organ. And so what happens? So people don't usually check the box, right? But different outcomes happen. On the one hand side, like on the left hand side, people don't check the box and they don't join. On the right hand side, people do check the box, but they join. I mean, they don't check the box, but this time they join, right? So the mere way in which question is phrased influences decisions. And it kind of says a lot about the way we make decisions, because sometimes we have this perception that we are in charge of our decisions, the way we dress in the morning, what we eat, or other decisions that we make, that they are under our kind of influence, and we totally in charge of our decisions. But this is one of the illustrations that we may not be as much in charge of our decisions as we think we are, and simple contextual things that, or context in which we make decisions may influence the way we respond. So without us even knowing or understanding. So, and a similar thing happens since there was presentation done for healthcare. It was interesting also to look at the Advanced Healthcare Directive. This is a very important form. And some people, when they look at the donation example, they would say, economists would say, well, those kind of decisions are not really important for people. They just don't really pay that much attention what's going to happen to them after that, because they're not going to be there. So it's, probably the reason why they respond so differently to the donation question is because they just don't care. But this is an example of something that we really care about. So what's going to happen with us before we die, and what kind of decisions we want to make regarding our care at end of life. And so, but what's interesting to look at this form, at the Advanced Directive form, it also has default. So default option, it's what happens when a patient doesn't check the box. So in the example with donation, the default was, there were two different defaults, right? Two different things were happening when people would not check the box. In the example, on the left-hand side, people wouldn't check and they don't join, but on the other side, they don't check, but they join, so different defaults. We tried to also to look, when I was in Pittsburgh, I was part of the study, when we looked at the advanced directives, trying to see if we would switch the defaults and advanced directives, would that influence decisions people make about their end-of-life care? And interestingly enough, it was actually really influential. So right now, the default and advanced directives do everything, give me all the aggressive care, unless I opt out of things I don't want, right? So I don't want to have CPR, I don't want to have nutrition or hydration. So default is set for aggressive care unless I opt out of things. We try to look and see what will happen if we switch default to comfort care. So default will be comfort care unless people really want to opt in. And so they, on the other form we designed was, the question was like, would please check the boxes if you want to have these interventions, if you want to have CPR, if you want, and when you don't check it, obviously the default will be palliative care or comfort care. And it was very influential. So we had 130 people in the study. They actually were making real decisions. There are two groups, one with comfort care defaults, advanced directives, and the other one was aggressive care. And when we asked them in the beginning, people like, what was your preference for end-of-life decisions? Everybody said that they want to have comfort care. So the preference for everybody orally expressed was for comfort care. But then their decisions were very different. So the proportion of patients choosing to forgo feeding tube insertion, for example, was 54% in the comfort default group and 26% in the aggressive care default group. And similar for CPR, 42 versus 20. So decisions were significantly different because the way advanced directive was framed. And interestingly also, when we, at the end of the study, when we told them that we explicitly said that we were trying to influence your decisions, we designed this form specifically with this kind of defaults in mind, would you now want, knowing this information, would you want to change your preference? And only 2% of people actually changed, so they still wanted whatever they choose, even though obviously their decisions were influenced in a way. Just very briefly, my research was in this area was end-of-life care, and why it's important because we have a growing population of older people, and it will grow to 20% in the United States. And so obviously older people may have multiple chronic conditions, and we spend a lot of Medicare money on last 2 years of life, and especially on last 6 months of somebody's life. And what's interesting about all the statistics, so this statistic is kind of jumped at me, that in a very, very large poll, 80% of the population, they said they prefer to die at home. But what actually happens, they actually end up, 80% of the population actually end up dying in the hospital, not at home. So preferences of people and what actually happens with them at the end of life, they don't match. So there is a mismatch between what they want explicitly, what actually happens. And the reason why there is this mismatch, because a lot of things that happen at the end of life, they just don't happen. It takes a decision. So people have to make constant decisions, even about the weight you die, when you die, how you die. It's always a decision, and obviously people don't make the best decisions. And so I wanted to talk about this concept of behavioral economics. So basically, behavioral economics, it's a relatively new field of studies that studies behavioral, it draws from behavioral science, looking at the way individuals make decisions, the decisions that are often irrational or non-rational and biased by a number of cognitive heuristics and cognitive biases. So for example, the traditional psychology or economics, the assumption is that people are very rational. We make decisions that are going to increase our well-being. We weigh options and choose the option that will benefit us the most. So the traditional approach that, to decision-making is rational agent who makes very careful decisions, weighing benefits and risks, and choosing something that actually going to benefit you in the long run. But behavioral economics talks about real-world decision-making, and in the real world that ideal person doesn't really exist, and sometimes we often make predictable mistakes that, and make decisions that actually not going to increase our well-being, but actually may harm us in the long run. We make decisions about our health, about our finances that are, we don't probably budget well, and so there are many things that we do predictably because our decision-making may be biased by a number of cognitive shortcuts. In behavioral economics, the approach to decision-making is they ask people to imagine the way we think as two cognitions, two different ways we think about a number of things when we make decisions. One cognition is very fast and frugal and almost intuitive, one system in our brain. And many decisions we make in that way are almost done instantaneously and very fast. Versus the other system is decisions are made very slowly, deliberately, we think about things. So sometimes we have these two systems in our brain that work together, but sometimes we rely on one more than on another. An example often I like to use this example to demonstrate how these two systems of cognition work together. It's a simple math question. The baseball bat and the ball together, they cost $1.10. The bat costs $1 more than the ball. How much does the ball cost? The very first answer that comes to mind is 10 cents. But if you think a little bit about it, that's not 10 cents, it's 5 cents, right? But the automatic, intuitive system really jumps first and says like, oh, it's 10 cents, obviously. And it takes a little bit while to think about it, and it's like, oh, okay, so I see now it's 5 cents, not 10. So that's the way the two systems of cognition work together. Just one of the examples. I don't know if you heard about this book, but it's been a bestseller for a number of years, written by Thaler and Sunstein, a book called Nudge. They proposed the concept of nudge or nudging people, knowing that we rely sometimes on this fast and frugal decision-making kind of system in our cognition. Is there any way to help people make better decisions by by modifying their context in which they make choices without taking options away, but kind of nudging or gently steering people towards better decisions for them? So that's the premise of the book. Oops. Yes. So they come up with this concept of nudge. Nudge are interventions that aim at suggesting one choice over another by gently steering individual choices in enhancing directions, but not imposing a limit on any available options. So nudge basically proposes to organize the context in which people make choices to minimize the impact of those cognitive biases or mental shortcuts or heuristics to make sure that people actually do make better choices. And so one of the examples they gave in a book of nudge, it will be cafeteria line. So we have to, when we put things on the cafeteria line, we have to design it in certain ways. And there are many ways to design it. If you want people to make better decisions and make healthier choices, you'll probably put healthy food in the beginning of the line. And something that is not healthy, you put at the end of the line. And so in that way, people will obviously choose more like fresh fruits or vegetables. So that's just the example from Simpson, right? Donuts are so difficult to reach to, so I'll just grab a fruit, right? Another example they give in the book, it's from Amsterdam Airport Schiphol. And they try to keep their restrooms clean, and so that's just one of the examples. When they put a fly into men's urinal, the spillage reduced by 80%. So, so simple intervention, but with very significant results. Another example of nudge is here. It's from Sweden, but they have a nudge unit as well. Another example. Same unit. Here's another example also from the same. So can we make people throw their garbage into trash can in a public park? During one day, and it's 41 kilograms more than the normal trash can right next to it. So yeah, so fun theory. So that's just an example of nudges. What's important to remember about nudges in all these examples, first of all, options were still there. For example, if people still wanted to take escalator on the stairs, they could still do it, right? They could still, there was no, no limit of options. We didn't limit their options. And there was no punishment involved as well. So if they choose escalator versus stairs, they would not be punished in any way. So sometimes when people talk about nudges, fines or any kind of punishment system, it's not a nudge because you don't punish people. You try and you don't take options away. Options are still there. And so there are two important concepts in this theory. So one concept is a choice architect. So the idea is that there is always somebody who's responsible for making or organizing this context in which people make choices to enhance those things that we actually want to, or to steer people towards the choice we actually want them to make. So for example, in healthcare, it will be doctors. Doctors are often choice architects. And why it's important, because especially in healthcare, doctors don't want to think about them this way. The assumption is that, well, as a physician, I'm just presenting information in an unbiased way, and people make their choices. You know, my role as a physician is just like I'm giving information, and people make their choices. But it's important to, especially for physicians or for many people who act as a choice architect, to remember they actually are. Because, for example, as a physician, you can lead with one information, start your presentation. For example, if there is a choice between surgical intervention or medical intervention, right? You can do surgery or you can treat something with medications. Even the first option you start presentation with, it will influence people's decisions. So people sometimes tend to anchor their choices, and they will go with whatever first option you presented. If you present surgical option, most likely they're going to choose surgery. If you present medical options, most likely they're going to. So even those small things can actually influence decisions. And so, but a lot of people who act as choice architects then don't really want to think about themselves that way. And so the other concept they suggest in their book and in the theory of nudges and behavioral economics, it's a libertarian paternalism, which sounds like an oxymoron. But the way they explain it, it's the libertarian aspect of this theory, or these strategies, nice strategies, it's insistence that people should be free to do whatever they like. So for example, they want to take donuts, you know, in the cafeteria, this thing can take donuts. We don't really prevent any options. But the paternalistic aspect lies in the claim that it's legitimate for choice architects to try to influence people's behavior in order to make their lives better, healthier, and make better choices. So libertarian paternalism, in a way, it sounds like Ulysses' contracts. I don't know if you know from Greek mythology, Ulysses, who asked when they were passing near this island with sirens, yeah. Sirens who they were singing and like trying to make them come to that island. He asked to be tied to the boat so he would not go there. And so like it was, in a way, libertarian paternalism or contract he made with himself. So libertarian paternalism is a very weak, soft, and non-intrusive type of paternalism because choices are not blocked, fenced off, and there is no significant burden on any kind of choice. But it's still paternalistic because choice architects, they're not merely trying to track or influence people's choices, but they consciously attempting to move people into a certain way. So in a way, the example will be how the strategy works is like a GPS system, right? The idea behind this is like life can be very complicated. Many choices we make about healthcare or other areas, they're very difficult. And GPS is needed to help us to navigate those choices. The goal of GPS is to promote simpler, better, more efficient navigation. And GPS works for many number of choices. For example, and GPS never punishes you, right? So for example, if you go to San Francisco and the best route is number 5, right? But you want to take 101 and go scenic route, GPS will adjust. It's not going to punish you or stop working. And sometimes it's even useful. GPS is useful for people who actually know how to get somewhere. So it's not we use GPS to get information about traffic or some other things. So similar with nudges. Nudges, often the role of nudges is to increase navigability and highlight some different informations. And nudges never impose any sanctions or costs when people refuse to be influenced. And they work also for people who even don't suffer from cognitive illusions or biases. So examples, in Florida, when I worked in the cafeteria, we had the system of each kind of food was labeled with stickers, red, yellow, and green. And so the idea that, you don't really take a lot of red things, like to stay in moderation with yellow and go wild with green. And so And so it was just a way, that was a nudge, but it was just a way to highlight important information so people would not start to think, oh, how many calories there, you know, is it healthy or not. It was just a nudge in a way to kind of bring salient information and make it more visible. So that's how nudges work. Why it's important in healthcare? Because there are a couple of assumptions in healthcare. One of the assumptions that physicians' non-involvement in decision-making is possible and desirable. And I made it comment earlier that physicians don't like to think about them as choice architects. But again, it's inescapable. The influence is there, and we do influence decisions of our patients. So for example, what kind of information we open our conversation with will influence their choices. Or for example, what kind of risk, or how do we frame risk information? Because when we talk with patients about decisions, we need to present risks and benefits of procedures, right? And so it's possible to frame it procedure as like 10 people survive this procedure out of 100, or 90 people die. 90 people survive this procedure and leave, or 10 people die. So the way you frame this intervention will also result in different decisions. Actually, there was a real-life study, very famous study, where they were discussing mastectomy with women, and those choices were framed as, in one group they said that mastectomy, you know, the outcomes, 10 people die from this procedure, and the other group they said 90 people lived, and so more people, significantly more people in the other group chose mastectomy versus you know, in the group where they said 10 people die, which is exactly the same information, just presented and you frame it in a different way. So, and the other assumption why it's important, because we think people know their preferences. The assumption is when people come to hospital or when they make important decisions, they really know what they want. But behavioral economics says that a lot of preferences of people are made on the spot. They've never been in this kind of situation. The constitution is very complex. And so instead of coming to the decision with very premeditated kind of values, they actually made up their values on the spot based on the information they received. So that there's never like really preferences that were premeditated. There are many advantages of nudges. One of the advantages, especially in healthcare, why we should probably use more nudges in healthcare, is because in this scenario, for example, when provider deciding what to talk about with the patient, and there is one way to present the therapy as a default. This is what we do as a default. This is our like standard procedure. On the other option is to give all the options and explain every single option. Well, we can do this, we can do also that, we can do also this, hoping that patient will choose for themselves what they want. And so the assumption in ethics is that active choosing is more ethical. That it's better to enable people to make choices for themselves, but especially in healthcare sometimes, they don't want to make those kind of choices. And they would rather actually go with the default because those choices are overwhelming. There is so much of information they never been exposed to. They don't really know how to process this information. So for them, it will be so much better and simpler to just to have a default option. But we as providers sometimes in the healthcare, we insist on the act of choosing because we don't want to be paternalistic. But the mere insistence on the act of choosing can be paternalistic in itself because people really don't want to make those kind of choices, and there is no way for them to escape because we force them to make those kind of choices. So, and sometimes also in healthcare, there are people who obviously make choices based on their cognitive biases or heuristics. For example, in this case, young man who was in an accident, crashed his spine, he's paralyzed, and he asking to remove life-sustaining treatment because he believes that life is not worth living as a quadriplegic. And so, you know, we probably in healthcare would not go with this decision, and we try to at least to influence it a little bit because we obviously see that the person has some cognitive biases, and he may not think that he will adjust to the life later on, but he will. We know that he will. And so helping or nudging this patient probably is a good idea, not just going with his decisions. So obviously there are quite a few ethical questions about nudges, so whether it's ethical to nudge people. since talking about ethics. In healthcare, there is assumption about nudges that why it's ethical because of two things. One, first thing, why we can nudge people in healthcare, because sustaining and promoting health is very important to everybody. Health is such of a great value that we're not imposing any unwanted goals or values on people. We know that for everybody, health is a good thing. And so we nudge them to be healthy, so it's permissible to nudge them because that's what people actually want. And the other reason why, because healthcare decisions are very complex and emotional. And so helping people a little bit, nudging them and kind of steering them to better decisions is permissible. But obviously, with these two premises, there are a lot of questions and problems. Like, for example, problem is number one, we do value health, but we also value a lot of other things as well, right? And we weigh those values and arrange them differently. For example, why we sit around more than we should, or why we overeat. So, there are a lot of things, a lot of reasons. It's not because we don't understand the value, but sometimes it's for relaxation, for celebration, for socialization. So we do make decisions or prioritize different values, and we balance those things between themselves. And also, even if we assume that health for people is the most important value, it's still people's conception of health is different for different people. So for example, in the ICU, because my research in this area was mostly in end-of-life decisions in the ICU. In ICU, for people, they prioritize different things differently. For some people, it's absence of pain is the most important. For other people, it will be maintaining cognitive function. As long as I have cognitive function, I'm great, but then, like whatever, to just remove me from life support. For other people, as long as my heart beats, that's what I want. So different people have different conception of health or what health is for them. And so we cannot really nudge people towards something uniform. There's also a problem with autonomy, and there's this quote that kind of captures it in a very good way, whether this intervention really promotes somebody's autonomy. And the author, Luke Bowman, he said, there is something less than fully autonomous about the patterns of decision-making that nudge taps into. When we are subject to this mechanism, heuristics or biases, then we are not fully in control of our actions. These are the cases of not letting my actions be guided by principles that I can underwrite. And as much as this action, they're not autonomous. So one of the objections to nudge is like there is no autonomy. It's not, we influence people and we not promote their autonomy. But the way authors respond to this claim is that influence should be in a way that make choosers better off as judged by themselves. And that's as judged by themselves is very important. For example, in GPS analogy, if GPS steers people towards other destination, not the one they wanted, it will be very problematic, right? And it's not working well. Same with nudges. Nudges should only increase navigability by making social situations easier to manage, but not driving people towards some goals that are not their own. And the other issue with nudges and the way to respond about autonomy, nudges sometimes are inescapable. There is no way to escape nudging people. For example, on the DMV form, you still have to put a default. There is no way to frame that question in a neutral way. We make choices between two defaults, right? Either we think that people will opt in or opt out. There is no third option. So sometimes nudges are just not escapable. You have to set them. Also, autonomy requires informed choice, and we can argue that nudges actually help people to be more informed. Just like the example in cafeteria with those stickers, we actually what we do is nudge, we inform them about better things. So we help them to process the information. So in a way, we increase their autonomy by doing that. There's also concern with manipulation, but whether nudges are manipulative. But not all the attempts to influence somebody can be counted as manipulation or coercion. For example, when we post calories on menu, we nudge people to eat healthier, but it's not necessarily manipulation, right? We wouldn't call that. And complexity in healthcare can be manipulative in a way, because sometimes what happens in healthcare, we ask people to make choices and we give them consent form of 10 pages with a lot of information. They just like, oh, where should I sign? I don't want to, So that's manipulation in a way as well. There's also concern about transparency, that nudges usually work when people don't realize that they're nudged. So But to respond to that, it's also not really true because, as the example with advanced directive, when we actually told people that they've been nudged and we explained, we've done this intentionally, we nudged you, do you want to change your preferences? They're still like, no, I'm still going to stick with what I choose. And there is no ethical obligation to be always transparent about everything. For example, when we try to make people not smoke and we present this scary information right in the ads with lungs and how smokers look like, we don't really tell people explicitly, we're not going to scare you with this, we just do that. So there is no, probably no obligation to do that. So there are a couple of ethical principles how to nudge people in an ethical way, especially in healthcare. So one will be when people have a greater capacity to make autonomous choice for themselves, the less we should nudge them. So when we see that people actually make autonomous rational choices, we should be less concerned with nudges probably. And when we're not really sure about the treatment we're going to recommend, when there is less evidence concerning the efficacy of a treatment or recommendation, we probably also shouldn't really nudge people towards something that we're not really sure that's actually the best way to go. If we actually really, we only can nudge when we have a relationship with patients and we know about their values, about their beliefs, and when we see that they make choices that contradict those values and beliefs, that's probably permissible to nudge. But when we have no relationship and we don't know what patient actually values, it's probably not really a good idea to nudge them towards something because we don't know what kind of, maybe they actually do have those kind of values and we're just imposing our choices on them. And the greater the potential or magnitude of harm relative to benefits, the less justification is there for nudges. So that's overview of nudges, and I can probably give you just a few examples in the end of life because that's what I worked with. But later on, I can maybe at another occasion, I can also talk about the way nudges happen and the way the cognitive processes work in the church setting, for example, how we perceive justice and fairness, how we donate money for some causes and why we do this and why we donate more for one versus another, mission work. Or so there are a lot of these mechanisms also that work in the church setting, and so at another occasion we can talk about it. But I just since I gave like an overview of the theory, I wanted just to give a few examples from end of life. So there are many ways to nudge people in the end of life. So on the part of the providers, putting in financial incentives for end of life conversation and advanced care planning probably will result in more conversations happening. And that has been proposed before and met with a lot of resistance. I don't know if you remember the whole conversation about death panels, SATA panel, call it. But now it's done. We do reimburse providers for advanced care planning. It results in more conversation happening and more people making choices, so which is a good thing. Also, like the way we talk about code status or CPR, providers often ask these kind of questions, which are not great at all. If your heart stops beating, do you want us to try and start it again? If you stop breathing, do you want us to put in a breathing tube? Do you want us to do everything? So obviously, if we ask this kind of question, the answer will be yes, of course. So it's very important how we talk about code status because CPRs are not as effective as media presents it to be. And so one of the ways to talk about it is maybe to use term allow natural death. So by using this term, we imply that there's a treatment involved. We're not abandoning people. We still treat them. But there is a natural progressive disease that happens. And also, given the fact that CPR is a social norm, it's probably a good idea to start discussion of CPR with in my experience, most people don't want CPR. So we set other social norm to counteract that mistaken belief. Also, we can frame palliative care. A lot of times when we talk about palliative care, we talk about this giving up, not doing anything. And there was a study also, I've been involved in a little bit in this study, when we looked at the way providers talk about aggressive care, ICU care, and palliative care. And when they talk about aggressive care, they always use this we should, we need, we may need to do this, he needs. But when we talk about palliative care as providers, we talk in a kind of could frame. Oh, we can do this, we may do that, the options include, so there is disconnect between the way we talk about those two treatments. And one other idea, we took it from antibiotic, overprescription of antibiotic issue. So in the past, providers were prescribing a lot of antibiotics, and it leads to antibiotic resistance. So we were trying to think how to counteract that, and we came up with an idea that every time providers write the script for antibiotics, there will be a pop-up window where they need to write the justification why they actually ordering antibiotics. And if you don't write the justification as a provider, if you skip that window, it will be in the chart showing that no justification given. And patients can actually see that in the chart as well. And so we try to implement the same thing for palliative care, where pop-up window will be in the electronic health records, asking providers to order palliative care in the ICU. And if they not early on, if they don't do this, there will be also no justification given for palliative care in the ICU. On the side of patients, it also incentives for completion of advanced directive. We do this now. People actually paid $75 to complete advanced directive. The other idea will be, instead of using consent forms for decision about fetal life-sustaining treatment, so when we talk about withdrawal of care, instead of using consent, use assent. So it's a very similar idea, but we don't really ask them what to do. In the consent form, is like we ask them, would you want to do this, or would you want to withdraw care? In the assent form, we say like our preference or our strong medical suggestion is to not to provide this care or stop or withdraw care, and that this is the reason why. If you disagree, you can still opt out of this, but if you agree, then we'll just proceed, and we're not going to offer you any more of futile care. And in a way, we take choice from people because people don't want to make the choice. We just present this as a default. And it helps people not to live with this kind of guilt and not to make this kind of very difficult choice. Because withdrawal care is presented as a default and an option that we strongly suggest and recommend. Also, it's important to, I mentioned, to think about the order of things, the way we present in conversation. And we talked about default options and advanced directives. So just a few examples from end-of-life care, potential ways in which we may influence choices of patients. And so this is related to healthcare, and hopefully maybe next time there will be also conversation about more related to church and our values and the way this happens in the church setting as well.
Thank you, Alex, very much. Now, we have some time for questions or comments. Who has the first remark to make? Let me ask you this. Do you think it's too coercive for a doctor to say, in our experience, most people don't want CPR? Is that a little bit too much? Jan is saying yes. More than one person, yes.
I'd just like to say, when the doctor says to me, here are your choices.
1 second, please.
I'm answering a slightly different question, I'm sorry. But even though I have a healthcare background, when the doctor says to me, these are your choices, that's not helpful to me because I'm not a doctor. I don't have the context with which to evaluate the data I'm being given. So I would rather say, okay, this is your diagnosis. The drug we normally prescribe for that is this. If this doesn't work for you, if you have these symptoms in 2 weeks, please come back and we'll do another drug. Okay, cool. And we move forward. So I don't mind them saying, normally people don't choose CPR. I'm not that old, sorry. You will do CPR on me at this point. My 92-year-old father, probably not. So.
Sorry I came in late, so you may have covered this issue before, but I'm concerned about the way in which language creates categories. And in fact, you take a word and change it, like nudge versus manipulation or influence or duress, all of which may very well have some input into the final use of, we make ourselves feel better by saying we're only nudging the patient for what we think is best. I'm concerned about the influence of money. I was going to ask you if the insurance companies funded any of your research, assuming not because of your field. And I want to point out that there are things that an insurance company will pay for instance, an end-of-life kind of prescription when they will not pay for treatment because one is more expensive. And autonomy is a value served mostly in the negative, I think, in the healthcare system. If the patient says, no thank you, I don't want CPR, then we're happy with that and we say the patient has exercised her autonomy. If the patient says, I want CPR, I think I want you to keep me alive no matter what, then we say the patient's not rational or the patient's not really exercising autonomy in the way that we think it should be exercised. And finally, I'd like to point out that Dr. Branson, for whom this class is named, refused to ever execute an advance directive. And we had discussions about that because he said, I'm not giving anybody permission to turn off the machine if there's a chance that I can live. So it's just a presentation of the other side.
Yeah, well, with CPR, it's usually when a lot of things happen and when we ask this kind of questions would be not necessarily the patient, but when it's, for example, 92 or 95 years old, grandma, and we ask their relatives this question, relatives like, oh, no, and we know as a providers that, like that person definitely not going to benefit, but relatives make this kind of choices, maybe then,
I think I may understand now one of the most annoying experiences in my life. Because I'm older, I watch a lot of television news. And pharmaceutical companies, realizing that only old people watch television news, send all these advertisements about these very obscure and very expensive medications with horrible side effects. But the nudge is this: while the voice is reciting those side effects, there's a beautiful, happy family cavorting and just enjoying life. Isn't that a big nudge?
Of course, yeah. Of course, that's very nudging people. And so one of the reasons actually for using nudge in healthcare, because people are already influenced. So again, thinking about the assumption that it's a neutral playfield, it's not there. There are many influences already present, like those advertisements. And so probably given the fact that we as a providers, we often want the better for our patients, and we already see that patients may already be influenced. So maybe we can actually counteract a little bit of that influence with being more intentional with our influences towards something that's
Thank you very much for your interesting presentation. Would is fair to say that in the process of decision making, excuse me, it's involved in situational ethics plus nudging, according to your presentation? That will be a fair assessment?
Yeah, it's situational ethics, but in a way, no, it's not really, because I show a couple of overarching principles that you probably have to think about when nudge. So any kind of nudge, if we, for example, if we don't really know about efficacy of a treatment, we don't nudge people. If we don't have a relationship, so there are principles that apply for all the nudges in healthcare, not necessarily case-by-case scenarios. So the whole idea, and especially in ethics, when we talk about nudges, to come up with some sort of principles that will be kind of universally applied when we talk about nudges, not situation by situation as well.
And also talking about the decision making, it came to my mind listening to your presentation the words of C.S. Lewis that said at one time that when we make a discovery and we have to take a decision about it, we are bringing to it our philosophy. In this situation, the philosophy, our philosophy of life.
Yeah, no, we'll definitely do. It's good fun.
I have a question. Well, first of all, it's a statement. I think this whole area opens up a whole area for someone going into law.
Yes.
I mean, you're going to have a lot of lawyers going to be dealing with these things
Oh,
for
yes.
a
Yes.
long time. I'm just curious, has there been any study as why people procrastinate in making decisions? I worked in trust services and deferred planning for years. Things like, which child's going to do this, or what's going to. Anyway, has there been some
Oh, yeah.
scientific studies for that?
There are a lot of studies. One of the big studies about this would be choice overload. When people presented with so many choices, that you kind of refer to that. There's choice overload. When you go to grocery store and there's like 100 salad dressings, versus like 2 or 3. So when there's too many choices to make, you just like, no, I'm not going to make any kind of choice. So that's one thing. There is also emotional influences. People sometimes in psychology, it's called ostrich effect. When people, try to avoid information, I just don't want to know this.
What was that word again?
Ostrich. Like
ostrich.
yeah, like when you hide your head, under the ground. Yeah, so there is the same, research. People sometimes intentionally avoid information. They just say, I don't want to know because it's too emotional or it threatens your identity. The information that you're going to receive will be, in conflict with who you are. So especially it happens, like in things like climate change or anything that when you don't believe it, but the information comes towards you, and you try to avoid it because, it threatens your identity. So there are a lot of research, and another research also. What's very interesting about this is nudges sometimes misfire. So there are institutions where nudges don't work, and it's interesting to research them. I can give later on an example about it as well.
The whole concept of free market, as I understand, is that people make rational decisions if given the facts, when in reality, that doesn't work at all. And consequently, I understand that back in the early part of the last century, when we had overproduction, that's when we went into mass advertising. And they used Sigmund Freud as kind of a basis for that. In fact, I think the relative was the one that put this whole concept of mass advertising to nudge, actually propagandize, and actually really influence people to buy.
Right.
Yeah.
Well, but with manipulation or propaganda versus nudges, it's, and we can talk also about it in other occasion, what counts as manipulation. So when we steer people towards something they don't choose for themselves, or something that is judged by themselves as good, that's probably coercive, manipulative. Or when people are scared into, or with nudges, we only nudge them towards something they really know they want, and we don't impose any limits, or we don't scare them. There is no punishment involved. So there's a little bit, slight difference between. One before other question. One interesting example was nudges not working in Israeli. Daycare centers, they tried to introduce nudge because people would come late to pick up their kids. So they were trying to think, well, how do they nudge people to come earlier, not to be late? And so they introduced like a small fine. So for each half an hour or 15 minutes increments, you'll pay additional fine when you come in. And actually what happened, they thought people would come in and pick up kids earlier. But now more people started to show up later because they like, well, now I feel justified. Before I felt embarrassed not to pick up kids. Now, I just pay the fine or whatever. So sometimes nudges do misfire.
We're going to have to call it quits, but Alex, Dr. Dubov will be here next week, and we'll continue at that time. I couldn't help but think of Dr. Provanch's thinking along these lines because I've been editing his paper, and the question is, for whom the nudge should be made? And most of us would say, I think quite automatically, it should be made only for the benefit of the one who is nudged. But he would disagree. He would say, not only persons who are also affected, we should nudge people, not just for that person. So I was a little arrested when I read him on that. okay, I have a request. We put these things out. Some of us are going to want to run to Second Church. Would there be anybody willing to put this away from us? Put these away so that we can go. Okay, thank you. A lot of hands. Let's read the benediction. The Lord bless you and keep you. The Lord make his face to shine upon you and be gracious to you. The Lord lift up his countenance upon you and give you peace. Amen.